Hello. It gives me great pleasure to bring in the next player. That's none other than Dr. Rohit Om Prakash. He would be speaking on multi-set injector system, a surgeon delight.
Yeah, absolutely.
Over to you.
Thank you, sir. So I would be taking up this enhanced monofocal from Hoya. So this patient had minimal astigmatism, and we decided that we'll go in for Hoya Impress IOL. So let's see how things went about. So you will see that what I'm going to do is I'm going to create a temporal incision because it gives me the ease, better assess. There is no brow in between. I'm using a bevel up keratome, and I had used, if you could see, the limbus because that gives a faster and a stronger healing. The next part involved is I would like you to see, I'm just because I see there are so many new people around, how I'm putting the visco in the anterior chamber so that there is a visco all around. It is a visco dispersive one. Next part is the, the stepson, which is usually ignored one, is the calibrated side port incision. What do I mean by this? I'm creating an incision, side port incision 500 micron, which calibrates with the side port instruments which I use. I am a fan of doing capsulorhexis with the capsulorhexis forceps. I go through the main incision. My concept is to create a capsulorhexis which should be adequately sized and which should be covering the optics all around. So I'm going around easing myself into a 5.1 millimeter capsulorhexis. The next part is the hydrodissection which I'm doing. I use a 27 gauge cannula for that. You saw the wave, and that was adequate for me because I thought that would be sufficient. Now you just see the parameters which I'm using. The parameters which I'm using is a 28 IOP pressure with the compensation of hardly 2 millimeter when I'm using the 2.8 incision, a 2.8 incision. So once that is there, so I'm using the flow rate is 23. So I'll be doing a modified stop and chop in this patient. So I'm using a balanced tip to my advantage. This balanced tip gives me the advantage of minimal wound side thermal injury and with an increased stroke length. So I would like you to see the side port calibrated, the chopper which I would be using. You will see that it just snudges in. It gives me adequate, maneuverability also because the difference is around 50 to 100 microns, a different part. So I'll be starting with the sculpting. I do sculpting to realize what type of, nucleus it is, and I found that it was slightly, on the harder side. So I'm going into the valley and and then trying to chop it, which I would be able to. The hold is good. There is no dangling of the nuclear fragment. Once that is done, the next step would be, I would be using the torque. See the place where I place the chopper, and I'll be giving it a rotation. Once that is done, since the chop was not adequate, I'll give it a 180-degree rotation, hold it firmly, and chop it to my advantage. And you will find that it has been chopped fully. So once that part is done, so I've decided now I'm going to chop these foot position 2 again, full thickness, try to separate it. Yes, I've been able to separate it. Rotate it. I'll not emulsify it because I would like that these nuclear fragments should be fully separated. And once they are fully separated, that is the time when I'm going to take them out. You see how I'm doing it, separating them. The vacuum is around 450. The flow rate is around 30, around 28 or so. And the IOP is still around 28 millimeter. Once these nuclear fragments have been totally separated, I'm emulsifying them. I'm bringing the nuclear fragments to, this was a slightly larger fragment, so I totally separated it. I'm not moving my phaco tip left, right, and center. I'm using my fluidics to my advantage. Again, chopping it, separating, and I find, I'm not able to, so I'll just go in, foot position 2, 3, 2, and then back, and then separating it. I took out the nuclear core because I separated the epinuclear part by pushing it slightly posteriorly. Now again, I'm using the phaco chopper to my advantage. I'll place it occasionally whenever I am, slightly anterior to protect the corneal endothelium. And here I'm again rotating. Don't go and fish for it because I'm a traditionalist by all means. Total separation. And once the total separation is there, then only I'm going to emulsify it. I'm doing it slightly, the more, harder it is, the more slower I go, because I don't want the nuclear fragments to have a chatter and create a situation where, the corneal endothelium gets, endothelial damage is there, last fragment is being taken out. So this is the end of the emulsification. So the pupil size, you will realize, is the same as it was at the start and now at the end of the surgery. This was helpful because there was no undue efflux of fluid from the side port incision. I am a great fan of using a coaxial one. So the coaxial I use is a curved one. The IOP is still the same. And with this IOP, with the bag empty, there is less of, pain which the patient feels. So I go in, the irrigation. So what I do is irrigation off and then I go in. So with this, my indications for using a bimanual is when it's a subluxated cataract, when the capsule is open. So those are I use a by-hand coaxial one to go right for the subincisional one. The IOL which I will be using will be the Hoya one with a multi-cert injector. So that has a 4-in-1 advantage. You can push it, you can rotate it. So this is the one multi-cert injector. This was the one, the Navex which we were using, but now we have a different one, slightly different one, which goes to a sub-2 one. You can push it, or this is the IOL which will be used, a 21.5 diopter IOL. So next is, I'm just trying to refocus it. So you can either push it or rotate it, and the depth management can be done. I use support it with the side port, this thing. There's a depth management with the insert. So it acts as a shield for all types of anterior chamber depths. So this enhanced monofocal is on a Vivinex platform. It's oxygen treated, subsequent to which the amount of opacification, posterior capsular opacification, is almost zero. It is glistening free, frosted haptics which help in, no sudden opening up of the haptics, which can create a problem occasionally. With this, there is an increased depth of focus. There's a 1.25 diopter defocus which is there. Basically, what they have done is they have played around with the central 2 millimeter zone. There are microscopic changes which are not visible as such. At the end, I just confirm whether the wound is there or not. So the dysphotopsias with this are as good or as bad as a monofocal, so the patient doesn't feel much. In our series of patients which we have used, the add-on which the patients require for the near vision is anything between 1.25 to 1.5 or so. And in these patients, if you do a micro mono, wherein you go hit the first on the myopia and the second side, so there the patients are comfortable with both distance and quite a bit for the near vision. Thank you very much for your kind attention.
Thank you very much, Dr. Rohit, for an excellent presentation. I think any questions for Rohit? I think what he has emphasized, I also personally feel, and I think all the people on the panel would be feeling, that this is one of the best injector system that is there. It's really a pleasure and an art to really push it in without any surprises. So ask you or Naren, you would want to say? Yeah. You always talk.
The Hoya session, I think we should talk about Hoya lenses, and very important because they have sponsored this, and not because of that, but I'm not flattering, but this is one of the best lenses I have ever seen, and I have gradually, I think the J&J guys are gone out now, I suppose. Gradually I'm changing over from Hyans to Impress, and I'm very impressed with the Impress lens. It's really fantastic. I think the world's best injector is a multi-cert injector. I think you should all give a big round of applause for Hoya for this wonderful innovation. It goes, I have not had one single calamity with this injector system. It's really fantastic. I don't use geometry. Anaga was talking about geometric and geometric plus. I use only geometric for both eyes or geometric plus for both eyes, depending on whatever the patient's requirement is. Both eyes geometric also, the patients are very comfortable, very happy. Their contrast sensitivity is very good, glare halo is very less, and overall it's a very impressive thing. Sharad?
Yeah, I think
some more checks are balanced. I think
no,
you can give it.
see, the problem is I was just going to say with the new pharma rule, for whatever you have said, at best they can give you a gift of 1,000 rupees. So,
No, sir, I think.
yeah. So that's the rule. 1,000 rupees दे देते हैं.
Sir, actually,
1,000 rupees and that should not have a tradable value.
Yeah, that rule is not applicable here.
After how many minutes can you repeat it? The 1,000?
No, sir,
Anyway.
actually, in terms of.
No jokes about. I think it's a fantastic
Yeah,
injector
no doubt.
system and.